I'm sure everyone knows, this BAPM produced a perinatal management of extreme preterm birth before 27 weeks of gestation, a framework for practice, and this was produced and published in October 2019. So in the introduction of this document, there's actually a statement that says that these documents are based largely on the original Epicure studies, which looked at birth before 26 weeks of gestation, with some additional data from other sources, and also used MBRACE, the report of survival up to a year of age in babies born before 27 weeks. And this was a report looking at January to December 2016, and was then published in, I believe, January of 2018. So that personally wasn't much of a surprise. Those were the sources I anticipated would be supporting this document, but I found it quite interesting the way they put it together, and I'm sure everyone here has read the guidance. But I thought the most pertinent bits when I was trying to figure out where the sources came from was actually looking at Appendix 1, which sort of talked through the evidence of outcomes for these extremely premature babies. And the way I went about this was to, given that we were going to be thinking about antenatal counselling today, I was interested to see in particular where the data for the infogram had come from, given that personally, that's what I refer to a lot, and I imagine that that's what a lot of other people refer to. And what I was able to pull out is that in terms of mortality or the survival rates of these babies, this seems to be sort of the pertinent data set, looking in particular at the non-coloured bars here, which come from the MBRACE report that looked at January to December 2016. And I thought the really interesting thing in terms of us using this as data to counsel people was sort of the information given here in the figure 3, in that these numbers, the common denominator is that this is the estimated survival if active resuscitation has been given in the delivery room. And if you compare sort of the numbers here, they're then reflected in our lovely infogram and this sort of survival data that we look at here, which I presume is what we all sort of use in the middle of the night when we're counselling people. And I'd be interested to know people's thoughts on that, because my automatic thought at that point is that potentially using this as a denominator, in that these are the babies who have had the active sort of survival focused care, is going to skew our data slightly, probably in a very favourable manner. And that I wonder whether then, this makes me wonder whether these numbers that we're giving parents are overly optimistic, because although you obviously would agree that it's ethical to have this discussion and agree for active resuscitation only in cases where it's appropriate, those cases by definition are going to be one that have more favourable factors other than the gestation at which they're being born. So things like being of a female gender, being a singleton pregnancy, and therefore they are more likely to do well. So I don't know if that's a good moment to have a discussion about that, or whether you just want me to finish, Alok, and we'll discuss at the end.
No, I think it's a really good opportunity to kind of think about the views of our other colleagues. So I was hoping, so Ali, if we start with you, what do you think?
Sorry, I missed some of that because I've got a really unstable internet service at work here.
So basically, what Anna's alluding to is that survival in this particular infogram at this particular point is based on the MBRACE data. Now, I think the two worries that I have about this data set is it's 1 year. It's not going to be a huge number. The other aspect that Ali's correctly alluded to, which I will come to. I didn't catch that. In our current data set is the fact that these are babies who have received survival-focused care, active care, as opposed to being babies, say, for example, all live births. So, you know, if you're counseling a mother at 22 weeks where the baby's not been born yet, you're kind of in a situation where there's still the potential outcome that this baby could be a stillbirth. There's still the potential outcome that this baby could end up not getting through delivery room management. but actually there's a choice here for the parents to kind of opt for no resuscitation at all. So I think and even my slight anxiety is when we present these figures to parents, they'll be based on very small numbers in the infogram. But the other aspect is, would they tend at 22 weeks to present a more favorable outcome in terms of survival for the babies? So just curious to kind of get your thoughts on that. What are your views?
Yeah, I mean, it's tricky, isn't it? Because normally when you kind of go down to speak to people, you know, it's just because they've been kind of transferred in from, you know, one of our, you know, kind of level 1 or level 2 hospitals.
Tricky.
So it is tricky because, like you say, the 22-week data based on this doesn't look, you know, as bad, does it? But you haven't got through the whole kind of labour process at this point, and whether they've decided that they want any kind of active resuscitation or not really. So I mean, this would, you know, you'd bring this up right towards really the end of the conversation. I guess once I've gone through all those bits about, you know, some babies don't, you know, survive the delivery process, etc., etc.
Okay, if I were to pose to you a question to kind of put it back and say, well, we have to use, you know, if the parents want to know that data, and clearly at 22 weeks in particular, survival is important. If you didn't use this data, what other data would we use? So actually, I'm going to come to Lever for that. So Lever, do you want to try and take that question on?
So other data on the BAPM framework is what you mean?
So not other data on the BAPM framework. I mean, is there any other data that might help advise us, or data that we might like to share with parents in this situation?
I think in this situation, I'm always on the side of cautiousness, but I mean, I'm not going to underestimate the chances of survival, but I'm also not going to blow them up or try to. But I think I would be honest, if it's counseling a 22-weeker, I will be honest to parents, and I will also say and ask them to figure out which favorable factors this baby has. If it's a girl, if they've had steroids, if they've had Maxelf, if they're in a level 3, well, then I will be not necessarily extremely positive. I will still be honest that there are high chances that this baby will not survive the birth process. But if they survive and they decide to go for active management, then there is a chance that this baby does survive. I will always also say, I don't know if it's your baby that is going to survive. I mean, maybe not in these words, but I mean, make clear that it's not because there is a chance of survival that it's necessarily that it will be this baby.
Okay, fair point. I think Lever has given us a very good way of not having to use numbers and figures, and I think we'll talk about that in our approach, in our framework. Charu, any views from you at the moment? Anything that you'd like to say, especially in the context of working in a unit where babies like this will present, but might need transfer?
That's right. I think, unfortunately, we had a couple of baby, 3 22-weeker over last Christmas in sort of 3 months period, and it was quite challenging. I think the way I approach is probably first exploring the parents' sort of concept, because it's quite important how your counseling will go to. So again, their understanding, what are their views, what are their expectations, and what are their understanding. I think that probably from like how you do all antenatal, preterm, anticipated birth, and it should be probably explore their hopes with very sensitivity that, okay, what you want, it's your babies. And I wouldn't be just concentrating mainly on the numbers by conveying that this is the higher risk, but at the same time, providing more like a balanced approach. So you would say that this is what we have at this particular time in period, the data available, which is small number, again, the percentage and the survival, I think it's as BAPM has given in the infogram, is much more easier. Again, it depends, but rather than just concentrating, oh, this will be the negativity, like this will be not at all the good outcome, but maybe a balanced approach, saying, of course, with the BAPM, you know, the 22+1 and 22+5 will have a different outcome, besides the factors like, as Liva mentioned, about sex, singleton, etc. Again, it's more like a gradual information that they can actually understand, and if we have the opportunity, but for us, it's a very quick, short time. And then we, as far as possibly, we just transfer. So after 3, 2, and 1 went to St. Peter's, delivered at 23 weeks, it was 22+5, and the other went to Luton, but did not deliver. So those are the one which I was involved, but I think by the time I went to reach to the numbers, they were not much interested. Again, there were 2 different type of parents. Some wanted more information, some just wanted what is the fact. So I think it's a very difficult situation, and conveying them the risk at it's individualized parents, how they accept, basically. I mean, these are my views.
Thank you. So I'm gonna share with you my view after after Anna finishes her presentation. So Anna, go for it.
Okay, thank you. So I think a really nice way to highlight as well, now that we've sort of ascertained that this data that we're using in our infogram is based upon those who we've actively resuscitated, was, if I'm interpreting this table correctly, so this is again included in Appendix 1. And if we look at the 22 weekers here and the total number of all births in this category, actually it was only 23% of these that were born alive and then received active care. So it just really highlights this sort of a quarter of the babies in that cohort are actually the ones that are then represented here, which I thought was really interesting. And then I sort of moved on from looking at the survival data to what we're basing the morbidity part of our infogram on. And that was mainly based on sort of this second figure here. And this comes from the Epicure studies, essentially, and looks at the prevalence of severe neurodevelopmental impairment. And they had quite a nice definition there, which had 3 points talking about sort of the functional aspect, categorization of cerebral palsy, and then profound deafness and blindness, which I think was interesting that isn't, I don't think, made particularly clear on the infogram, actually, which might be a useful addition in terms of, you know, when you're counselling someone at 2 a.m. and someone asks you, what does that mean? What does that severe disability mean? Basically they've again compared with other countries here, and they've used this data to sort of come up with our 1 in 3, 1 in 4, and these are the figures that are then represented here on the infogram. So I thought, although it's necessary to extrapolate that data from a different study, because the Epicure is what focused on that was the point of those studies, focusing on the long-term neurodisability. I was then sort of meditating on what is the denominator in these babies. But actually, from the way I could wrap my brain around it, these are obviously by definition children who have been actively resuscitated and have survived as far as the NICU and have survived sort of being discharged. So a slightly different denominator to this group, which I thought was really interesting. And the thing that then has struck me, although I think this infogram is great and I have used it regularly, I very much, after looking at all the data, I look at this and think, this is a population. This doesn't relay to the parents or to anyone, that individual baby. And I just want to share this. You might have to slightly use your imagination for this, but I actually examined some of my students giving presentations this morning, and one of them had a really lovely infogram, which I think BAPM should consider. Obviously, you would have to slightly change the point because this lecture was on nephrotic syndrome, but I just want to show you the infogram to give you an idea of how they got around trying to show sort of society-based or a large cohort-based data as an individual. There we go. So I'll just make that a bit bigger. And they described it as a game of chance, which I think was quite an interesting way to describe it, given that we have this one individual. So they highlighted a group of, say, babies that are being born at 22 to 23 weeks. And this is our individual. And although I'm not suggesting any of these babies have focal segmental glomerulonephritis, this really nicely highlighted, I think, the fact that this individual can be within this group who's going to survive delivery, they're going to survive resuscitation and get through to the NICU. But also they might similarly end up in this group who survives but has a severe neurodisability. And I just thought this was a really nice visual way of representing to parents that these are our groups, this is the data we have, but I don't know which of these individuals your baby's going to be. Just to, I don't know, I guess highlight the limitations to them of what we're telling them. Okay. And I will end there and stop talking.
Thank you so much. I mean, that's absolutely amazing. What I'm going to do is I'm just going to give you a little bit of my view as well. Share my kind of view with you. So can you see that? Can everybody see that? So that basically is the data that Anna just showed us with regards to how BAPM has come about looking at survival at 22 to 26 weeks of gestation. Clearly, this data set is an annual data set, which is basically being used from data collected by MBRACE in 2016. So as Anna's pointed out, 486 births, which includes stillbirths, 290. So we lost about 200 babies as stillbirths in this data set. Of that, we lost a further 107 babies approximately during the process of birthing, so that we had 183 babies born alive. We then, of those 183 babies, had 155 babies who died in delivery suite. So, I mean, if we look at the numbers that we're left with about kind of, I would say it says live births receiving active care 43, but actually only 33 of those babies in that data set actually are surviving. So it kind of means that we had 43 babies who we offered active care to, and I mean, it looks as if 33 were actively managed, and we basically, after those resuscitations, had a data set for survival where we had about 15 survivors to 1 year of age. So, I mean, if we look at that entire journey from 486 babies, we had 15 survivors. And we obviously, with those 15 survivors, are not going to have enough data to actually be able to provide a subset of neurodevelopmental outcomes for those babies, because it's such a small number of survivors. So again, my slight anxiety, as I believe Anna's alluded to, that the numbers that we're looking at is a very small cohort over 1 year alone, which kind of has to inform our practice and informs the pictogram. Now, obviously, the arguments that we might have is this data set is going to grow, and there's absolutely no doubt that, in a few years from now, we're going to have much higher numbers. I think if you look at this data set, it's local, it's representative of population in the UK. That's one of the other important things. And clearly what it reflects is a significant proportion of babies having comfort care. So kind of an approach where obviously it looks as if the parents are being counseled and given a choice in circumstances where we would talk to them, and we would talk about the risk of neurodisability and the risk of survival, but we'd also be talking about a lot of other things, in particular the journey that their individual baby might take after birth, survival journey that it might have to take, the kind of procedures the burden of treatment that we're going to have to offer babies like this, which will influence their judgments with regards to whether they want resuscitation or not. So, I mean, if I summarize, I would say it's the data that we have available. It's our data, and I feel quite strongly about the fact that it is data from the UK. And if you look at other countries addressing similar questions, they would look at their data nationally, and they would try to make judgments of that in developed countries. And if you look at Sweden, say, for example, again, very proud of the Express data, very similar numbers, if I talk about Swedish numbers. Similarly, if I look at Japanese data that we will be sharing with you as the course goes on, clearly they have much larger numbers. And actually, they've been collecting their data sets from very early on, as early as 2003. And survival for a baby at 22 weeks in Japan in 2005 was about 37%. So, for those babies who we admitted to intensive care, the figure here is about 50% survival. But for those alive in labor, the figure is 5%. Now, I'm going to put you in a spot. So for a mother who comes to you at 22 weeks, what figures are you going to quote? So let's forget the infogram. Let's just look at these figures for survival. So what are you going to use? Are you going to use survival figures for those alive in labor at 22 weeks at the start of the pregnancy? Or are you going to use figures for babies admitted to the intensive care unit?
I feel like it might be a bit presumptive to use figures of babies admitted to the neonatal unit, because her baby is not there yet. It's not even born.
Completely. And that's my only other anxiety about using the infogram at this particular point, that there are outcomes other than being admitted to the neonatal unit that are possible and would depend on how the pregnancy is. And what we're going to do is I'm going to give you a scenario each to kind of have a think of in the context of that data. Now, I asked Leva kind of a question about what other data might be available. Now, it's really interesting. If you go to Norway, and when you are able to access the survival study data, there is a document by the Norwegian Institute of Public Health. Now, clearly, they've recognized that they don't have this data. And their view on it is very much that actually what they should be doing at a national level is actually looking at data sets from equivalent other countries which have similar health systems, and their health system is very similar to the UK health system, so that they can get a feel of survival in those settings and the risk of neurodisability. So they've done a meta-analysis of all those studies, and they've come up with data which kind of guides them, where, again, they're very cautious with how they counsel parents at 22 or 23 weeks of gestation. But it's a very interesting document to read, in that they don't feel that having data sets as small as this would be informative enough to give parents in their country as good an idea of survival and neurodevelopmental outcomes. It would be better to collate data sets from other similar countries, bring them together, and actually they've then produced a document based on that, which is, I would say, very similar in what it proposes to what the BAPM document proposes, but obviously a little bit more circumspect in the figures that they quote. Now,